Welcome to Dental XP. My name is Mario Steigman. I'm going to give you a small lecture about implant aesthetic and the anterior zone. I'm coming from Heidelberg, Germany, where I have an office and the Implant Teaching Institute, where we are teaching young implantologists about implantology basics, aesthetic, and sometimes also advanced cases. I'm organizing a meeting every year with this purpose for teaching the people which are interested in implantology. Today I'm going to make you a short presentation about immediate loading without occlusion using the natural crown of the tooth after extraction. What we are doing in these cases, we are placing an implant immediately, graft the site between the implant and the margins of the socket, and then use the natural tooth after we hollow it to maintain the soft tissues. In cases where we have a diastema, it's very difficult to predict the outcome aesthetics interproximally, the height of the papilla, the buccal margin of the soft tissue. And if the interproximal height of bone is receded, if we have a class 2 or a class 3, the outcome becomes even less predictable. In these cases, we are using the natural tooth. After extraction, we hollow the crown and then we reglue it to the implant abutment. Flapless surgery is a very modern method in our days. In cases in which only the tooth is compromised and not the soft tissues or the osseous form, flapless surgery can be performed. So the contact point becomes an issue. We extract the tooth. First we check the socket if the buccal plate doesn't have a perforation. If the buccal plate has a perforation, we are going for another approach, making a flap at the buccal site. This approach is called the aesthetic buccal flap, so that we can still preserve the soft tissue around the crown and have the guided bone regeneration to restore the thickness of the buccal plate and not disturb the soft tissue. The proximal height of bone is a major issue in late loading. In immediate implant placement and immediate restoration, maybe it's less important. The 3D positioning of an implant has a key impact on the aesthetic outcome. We are controlling the buccal palatal position, the mesiodistal position of the implant, and after we extract the tooth, we are controlling the length and we are trying to engage minimum of 4 mm above the extraction socket for primer stability of this implant so that we can make immediate loading. Also, the depthness of the implant, apical corner, is of major importance. We are trying to stay 3 mm from the gingival margin. Then we are placing the implant, grafting the space between the implant and the bone. We are usually placing the healing cap on the implant so that we take care that no grafting material is getting into the implant body, which will make the insertion of the screw more difficult. In these cases, after 6 months using the natural tooth, we see that we can keep the emergence profile. We are trying to fix the position of the tooth with the jig, so after we place the implant in position, we can replace the natural crown exactly how it was before, so we are not pushing the soft tissue forward or to the palatal. The most important aspect is the buccal aspect, because in these cases we are trying to maintain the soft tissue margins and not have any buccal recession on these cases. Spray in the literature showed that we need a minimum of 2 mm of bone to avoid a future recession or resorption of the buccal plate. If this is not the case, we are trying to graft even if the space between the implant and the buccal plate is 1 or 1.5 mm to avoid future recession. Here in the middle picture you can see in this implant system that we have temporary abutments out of plastic. Then we are taking the natural tooth, hollowing it, adjust it on this temporary plastic abutments, and then replacing it and gluing it with temporary cement. After 12 months with the natural tooth in position, we don't have any signs of recession, and we could maintain the interproximal soft tissue at its level. Then we go ahead and we are restoring it prosthetically using the impression coping, and after we send our impression coping to the lab, so for the cast to be made, we are repositioning the natural tooth back so we don't have any collapse of the soft tissue in the time when the final crown is made in the dental laboratory. As you can see here, although we have a diastema and the interproximal height of bone is resorbed, 1 year after we are placing the natural tooth and 2 years after we finished the porcelain fused to metal crown, we have a very good aesthetic result. Thank you.